Hello, this is Danny Van Leeuwen. I'm Health Hats. Good to see you. Thanks for joining me. Um, so, today we're going to talk about making clinical choices. So, getting from our health goals or our medical problems to um, making clinical decisions. The so we have, just to review, we have our personal health goals and we have our medical problems that sometimes align and sometimes don't. We have a health team, and our health team includes us and our care partner, or caregivers, clinicians, support staff, etc. And we are constantly making choices and developing a care plan to figure out who's going to do what, when are they going to do it, and it is full of clinical choices and clinical decisions. Now, there are, on the health journey, there are different situations, as we've discussed before. There's when you're well, when you're acutely ill, when you're chronically ill, or you're at end of life. And those, um, those situations can be different relating to the choices that you make. When you're when you're well, and your personal goal is to stay well, the kinds of decisions you're making are mostly preventative. So, am I going to have a flu vaccine, the pneumonia vaccine like I had last week? Um, are am I going to pay attention to cholesterol reduction? Am I going to try to prevent an adverse drug event? Um, so, there are things that are decisions are a lot preventative. When you're acutely ill, they're also preventative. Adverse drug events, preventing falls, preventing infections. But then there's like decisions that can be made, treating cancer of the prostate, treating breast cancer, having treating a deep vein thrombosis, a blood clot in your leg, or having an upper respiratory infection, and how's that going to get treated? Lots of choices, clinical decisions to make. When you're chronically ill, there's other sets of decisions that are made depending on your chronic illness. So, if you have a heart condition called atrial fibrillation, what kind of medication are you going to take for that? If you have high blood pressure, how are you going to manage that? Or how are you going to self manage? And how are you going to medication manage? Um, there's and diabetes, there's a whole slew of decisions that can be made. At end of life, there's making care planning decisions, advanced care planning, what settings, and there's managing multi-pharmacy is a big thing at end of life. Um, the So I like to give you uh, 6 different scenarios where that might reflect the continuum and variety of activities that happen around making clinical decisions. So the first one is around childhood immunization. So childhood immunization, there are protocols for childhood immunization, and both parents and clinicians, pediatricians, think about this stuff. And the um, the parent may or may not want to follow the protocol. There is a cohort of people who are against childhood immunization, but it's a one-time decision. Um, you do it or you don't. Then there's something like stopping smoking. Now, this could be a patient's goal, my goal, your goal, to stop smoking. It could be that there's certainly protocols that recommend it, and certainly um, clinicians are always recommending for anybody who's smoking to stop smoking. But that's a that's not a one-time decision. That's a continuous. Stopping smoking is a habit change, which is different than an immunization, which is a one-time decision about getting it or don't getting it. But you can make a decision to stop smoking, but to stop smoking is a continuous. And what you are trying to stop smoking may or may not work. Let's take a third scenario. So, I'm getting to be an older man, and like, when a bunch of older men get together and talk, they talk about their trouble peeing. Um, and that's a functional um, problem. And it's both a personal goal to, deal with whatever problem you're having peeing, and it's a medical problem. Um, so there are choices that can be made. There are protocols about there are tests to be done, like the PSA, and there's choice of treatment, and it's a patient choice. So that's like a different scenario. Let's take another one, number 4. Um, there's the risk of cardiovascular risk. So if you think about that, there are a bunch of tests that can be done. We've talked about this before, where your cholesterol, your blood work, your family history, etc. And the patient may be aware of this or not aware of this. And probably most often it comes up through the clinician. The clinician um, is following a protocol and driving towards a decision and possibly recommending a statin. And this is something that is another thing like smoking, is it requires a habit change. And it can be that you don't take the statin, you take it intermittently, or you take it regularly. And it may or may not um, reduce your risk of cardiovascular disease. Another scenario is if you're hospitalized with a serious illness, and you are in the ICU and you're going to get a central line. And so a central line is a IV intravenous directly into a big vein, and it's a high risk of infection. And I would say most patients are unaware. Some of their caregivers may be aware, but this is something that's clinician initiated, and there are infection prevention protocols, and there are decisions to make about following those protocols. And so there could be a scenario where um, you're a caregiver of somebody in the ICU and they're not following the protocols. And so you're bringing those protocols to the clinician's attention, or they're bringing them to you. And then the last one is a scenario that's more of a near end of life decisions related to discontinuing antipsychotic drugs for persons with dementia. And one of the challenges for people, for the elderly, whether or not they have dementia, but in this case, dementia, is polypharmacy, just taking gobs of medication. And so it could be that this is something that the caregiver, care partner, wants to have happen, is to eliminate or to withdraw from an antipsychotic. And there are protocols for that. And the clinician may or may not be aware. So different scenarios. Now, why is that important? It's important because if we're thinking about the world of clinical decisions, making choices, and clinical decision support, which is help making, materials to help make decisions, you're starting with a personal health goal or a medical problem that sometimes may be in alignment. There is research available about those choices. And so there's the factor of being aware of that research and decision aids. And sometimes it's the patient and caregivers that are aware, sometimes it's the clinicians that are aware, and sometimes it's both. And there's a matter of communication. How do how does everybody work together as a team? How do they communicate their goals, their preferences, the evidence, the choices? Um, so communication. Then there's one-time decisions, and there's decisions that are involved in habit change. Those are very different. There's the alignment of the patient and the clinician, that they're making the same decision, that they are working together. It is much more likely that a protocol will be followed if the patient and the clinician are in alignment. And finally, there's always, did it work or didn't it work? Um, just because there's evidence to say that something is likely to be effective doesn't mean it is for everybody. And it's important to know when they are and when they aren't. So we've been talking about our health journey. We've been talking about our health goals and our medical problems and making clinical decisions and some of the scenarios around making those decisions. Thanks a lot for joining me. I appreciate it. Take care. Onward.